All of you. A warm welcome to Zoom webinar organized by GMOA and Society for Health Research and Innovation. Today's webinar is on a very interesting and important topic in our day-to-day practice in delivering primary healthcare setup. Depression, the missing diagnosis. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts. It is my pleasure to introduce today's speaker, Dr. K.H. Dhanusha Mahesh, consultant psychiatrist attached to the District General Hospital, Mathura. Over to you, sir.
Good morning to you all. And I'm Dr. Dhanusha, psychiatrist from District General Hospital, Mathura. It's a great pleasure to meet you all. The very first lecture of the new year, and I take this opportunity to wish you a very happy and a prosperous and less stressful new year ahead. So we'll start this lecture. I know it's a bit difficult, these webinars, it's not, it's less interactive, obvious, but I will try my best to keep you all awake. And we'll see why I choose, out of all the topics, why I choose this topic, depression plus. You could see that this is a missing diagnosis. Are we missing depression? Yes, we are missing depression. And I will let you know, we are not missing our clients, our patients' depression. Even we ourselves miss our depression. So it's very important, at least not for our clients, not for the others, at least for us, to see whether we are depressed or not. So we'll move on. Before I start my lecture proper, we'll watch a small video. That's not about depression and nothing related to depression. Just look, this is only a few seconds, and we'll watch this first. But before watching this video, keep your all phones and everything away and focus on the video. So there's a question asked from this video clip. I will start it first and then we'll let you know. We'll try to share this video. Right. So she's helping me. Right. This is a test of selective attention. Right. So this is a small video, and what is the question is, in this video you will see the two sets of players, three in each group, wearing blacks and wearing whites. So 3 people wearing black and 3 people wearing white. They play basketball. And what is the question is, people who wear white pass their ball among themselves. So the question is, how many times they pass their basketball among themselves. So please watch very carefully, otherwise you will miss the count. That is why I ask you, keep away all the phones and other things. And then this is a test of your attention. You can check your attention and concentration, especially the attention, how better it is. So don't, if you are, losing your attention and concentration, you will not get the correct count.
Count how many times the players wearing
This is the question I explain you. Count how many times players wearing white pass the basketball, but not the black people. Okay, right. We'll start now. Right.
Pass the basketball. How many passes?
Right. I think it's a very small video, and you will have your answer with you. So this is not interactive, but you can just tell your answer by putting your answer in the chat. Yeah. So can you take 1 or 2 minutes Just to, can someone tell the answer? 15, right. Okay. 15, 14, right. And any other answers? Now we have two answers, 14, 15. 17, right. I know now it's about a range like from 13 to 17. But we all have only one answer. Before going to the correct answer, I have another question. In this small video, what else other than the white people passing the basketball among themselves, what else did you see other than 3 white people passing this ball? Can you just give me a short answers by chat? What else? Anything else that you, I mean, there are a lot of things. Obvious that you saw another 3 people wearing black. Anything else? No. Very good. People wearing black, they pass the ball. Right, good. Right. As the time doesn't permit to, you know, to drag this on, I will ask directly, have you all seen, other than these black people, have you all seen another person? You know, all about 6 people, that 3 in white and 3 in black. Except those 6, any other person came into the playing ground, the playing room, other than those 6. Have you all seen anyone else? Someone with mask is like a monkey face. Now the question, can you please, I know you all are doctors, and to be honest with others, can you all say the people who didn't see this monkey, the person with a mask, monkey or a gorilla, right? You can say yes or no, to be honest with you all, right? Do we, yeah, someone say? They didn't see. Okay, fine. At least only one, I mean, at least one person, if they didn't see, then I'm pretty sure that more than one, right? We will go back to that video again, right? The same video I will watch now. Be relaxed, and you don't have to count now. Just watch this video again, right? So the same video I will go back and play again, right?
Count how many times the players
Now
wearing
watch.
white pass the basketball.
Because some people say that they saw a gorilla or a monkey. Now you all can see.
How many
Okay,
passes
we'll
did
check
you
the
get?
count as well. It is
The correct
15,
answer
right?
is 15
Right.
passes.
People who did not see this gorilla, I mean, don't worry about that. The people who saw, I mean, they don't have, you know, extra powers. This happens because we miss this. I'm not going to explain what is the exact psychological phenomena why we miss this gorilla or the monkey, and that is a different thing. But what I wanted to tell is, like, even though we focus our attention, still we can miss things around us. And sometimes people say, like, you know, the other times I played this, people say, doctor, you asked, or you asked to just watch and focus on this and count. That is why we didn't see this gorilla. But it's not a valid answer for me, because you all saw these other black people. They passed their ball, and then the wall behind those people, you saw everything, but other than this monkey, people who didn't see, right? So that is nothing to worry about. Even the first time I didn't catch this. So what I wanted to tell is, still we can miss things, right? We'll go to the lecture. Right. That is why I said this is depression is a missing diagnosis. in around the world, it is same, not only in our country. This diagnosis, we can miss it. We'll see what is depression and what we all have to know about. So this lecture, mainly I focus on the doctors who are non-psychiatrists, like, the people who are in other specialties and the other medical officers. So this is not for the psychiatrist. Right, we'll move on. Little bit about the background. Depression is a common mental disorder, and it is one of the commonest throughout the world. And it's 264 million people of all ages suffer from depression in the world. And more importantly, it is the leading cause of the disability worldwide and is a major the contribution of the overall global burden of the disease. So you can see worldwide what is the importance of depression and to treat it. And it is more common in women, and it's 3-1. This can lead into suicide. That is the other important thing why we need to treat depression effectively. When we take suicides, and not all suicides are due to mental illness, but the suicides due to mental illnesses, due to psychiatric disorders, the commonest psychiatric disorder is depression. So in that point also, we need to effectively and promptly treat depression. Right? And luckily, we have effective treatment. We know that decades ago, we didn't have much treatment options, but now we have a lot of treatment options for depression. But unfortunately, still, it is underdiagnosed, misdiagnosed, or undiagnosed. So it happens even by us. As psychiatrists, we know little bit more about depression than you all, but still it happens from us. So we have to focus and pay our attention and concentration to catch depression. Depressed patients go first to their GPs and other specialties. That is why mainly this is important for you all, because normally depressed patient, not only in our country, and throughout the world, the global situation is they first go to their GP and other specialties before coming to psychiatrist or a mental health care worker, mental health worker. So it is important from GPs and other specialties, the other doctors, to catch depression and to treat it or refer. Lifetime prevalence is about 10%, and the 1-year prevalence is about 2 to 5%, depending on the different research data. And the mean age of onset is 27 years. This doesn't mean that the older age or younger people, they don't get depression. They are getting depression. As I told you, it's 3-1. It's more common in women, and it is higher among unemployed and divorced. And it is comorbid, especially with anxiety and substance use disorders, including alcohol. What are the barriers to effective care? This is what we all need to, as doctors in our country, this is what we all need to focus on and find out why we cannot provide effective care to our people. It is lack of resources. This is, now it is not worsen as earlier, because in 2004 we had the tsunami. At that time we had only about 25 to 26 psychiatrists in our country. The whole country had only 25 to 26. That was in 2004. We badly needed psychiatrists at 2004 after the tsunami. But now the things have changed. Now it's about more than 100. It's about 120, 25. It's changing. Psychiatrists working throughout our country. And the second is a lack of trained healthcare providers. It is a team effort. We all know that a psychiatrist or a doctor himself or herself cannot treat depression effectively. It's a teamwork. There are a lot of team, in multidisciplinary team, we have psychologists, psychiatric social workers, the community mental health workers, psychiatry nurses, and counselors. It's a teamwork. So we don't have trained healthcare providers, adequately, enough people. So that is one other reason we cannot provide effective care to our people. And the social stigma associated with mental disorders, that is, not only here, in all the countries, the social stigma is there. Because of that, people, they don't come to us. And inaccurate assessment, this is what we are, in this lecture, what I want to mainly focus on, this inaccurate assessment. This is not penalized to you all, because we all know that even psychiatrists, sometimes we can miss depression. It's not a simple thing as you all think. This is ICD-10 criteria of depression. We all know that we diagnose psychiatric illnesses, international classification of diseases 10, or the DSM-4, now it's 5. 3 main criteria: depressed mood. This is basic things, so I will move little fast. Depressed mood, loss of interest to the pleasurable activities, and the reduced energy. 7 minor criteria: reduced attention and concentration, reduced self-esteem, ideas of guilt, pessimistic views about the life and the future, and the ideas of suicides of the or the self-harm, and disturbed sleep and reduced appetite. So those are the minor criteria and 3 main criteria. According to these, we categorize this mild, moderate, or severe depression. I'm not going to detail of that because the focus is different on this lecture. And other than that, we all know, like in our medical school, we have learned that depression is a neurotic disorder, and there are another set of disorders called psychotic. But in depression, we can see some psychotic features like delusions and hallucinations. So what are the delusions we can see in depression? Those are nihilistic delusions, delusion of guilt, poverty, persecutory, and hypochondriacal. I will let you know, because the people who come to us, they don't say that, doctor, I have a nihilistic delusion or delusion of guilt. What is a nihilistic delusion? If I say how people describe this, that is the most important thing. Even day-to-day practice, you all can meet these people, but we miss it, those people. The nihilistic, what they say, මගේ බඩවැල් වැඩ කරන්නේ නැහැ, මගේ මොලේ ක්‍රියාකාරීත්වය නතර වෙලා, මගේ ඇඟේ යම් යම් ඉන්ද්‍රියන් වැඩ කරන්නේ නැහැ. This is what they all say. So some of my organs are not working properly. That is a nihilistic delusion. And delusion of guilt. මම වරදක් කරලා තියෙනවා, මට ඒකට දඬුවම් ලැබෙන්න ඕන, මට මේ වැරද්දට කොහොම හරි දඬුවම් ලැබෙන්න, මට හැම වෙලේම මතක් වෙන්නේ මම කරපු වැරද්ද. That is a kind of guilty feeling, but when it's amount to the delusion, they firmly believe it. And the delusion of poverty, මට කිසි දෙයක් කරගන්න ශක්තියක් හයියක් නැහැ, මට හැකියාවක් නැහැ. Persecutory delusion, we all know that මට කවුරු හරි අනතුරක් කරાવી කියලා බයක් තියෙනවා, doctor. That is how they present. And the hypochondriacal, this is pretty common, this hypochondriacal delusion. They say මට මොන හරි ලෙඩක් තියෙනවා, මම මේකට ප්‍රතිකාර ගන්නවා, තනින් තැනට යනවා, they do doctor shopping and go consultant to consultant or the GP to GP, saying that it's hypochondriacal delusion. මට ලෙඩක් තියෙනවා මොන හරි, මට ඒක හොයා ගන්න, ඩොක්ටර්ට මට උදව් කරන්න පුළුවන්ද? And they bring whole lot of investigations. So those are some of the delusions can present in depression. And the hallucinations, secondary and third person auditory hallucination, that you all know. What is the risk of depressed patient? Obvious, the suicide risk is high, and you have to check about when they last felt suicidal ideas and the frequency. And the homicidal, it is not common, but in depression, homicidal risk is also there. Infanticide, in the first year after the childbirth, we take this as a postpartum period. So infanticide, it happens in our country. And then self-neglect because of depression, and they can abuse by others. So those are the risks involved in depression. Why we miss it? Again, we try to focus on this. Why we miss this? There are factors why we miss this important diagnosis. One is patient factors. Patients are not always obviously depressed. We think our depressed patient is like, they come to the clinic or to the examination room very slowly, look downward, they don't talk, they don't smile, and it's like a pure depression. No, not always they come with all these depressive features. This is the, the textbook features we all know, but we cannot see in each and every patient all these features. And they frequently have a physical complaint. This is what you all have to know. Like, sometimes people come, Dr. Mage konde kakkuma tiyena, and they come again and again. You also treat and then investigate, doing everything, but everything seems to be normal, but still they come with a similar complaint. So that is usually they come with a physical complaint. Then we also focus on this physical complaint and we miss the diagnosis of depression. Because of depression, they have this pain. And increased somatization, again, more or less similar, this physical complaint. Somatization is the people who complains about their bodily complaints involving 2 or more systems. Like, if someone comes and say like, Dr. Mage bade amaruwa, konde kakkuma dina, belly pettakka kiyenawa, bade kakkumak tiyenawa, kakul deka ridena. So, and husma ganna amaruwi. So it's like, involving 4 or 5 systems. I mean, I don't see each and every patient you label as depression and don't think about the other diagnosis. After excluding all organic things, think about depression. It is kind of a somatization involving multi-systems. And the other patient factors why we all miss this depression, this important diagnosis, more accepting of physical than psychological diagnosis. The patients are also, they don't like to, because of the social stigma, they don't like to, accept that they have this psychiatric diagnosis. Ayo doctor mate hemana ekak penna widiyak naha balanna bැරිද scan එකක් කරලා because I have this pain, or else I don't think that I have this psychiatric diagnosis. Because of the stigma, they don't like to accept. And then depression coexists with the physical illnesses. Sometimes with physical illnesses, these chronic illnesses like diabetes, hypertension, chronic renal failures, and all sort of illnesses, depression can coexist. Because of these chronic illnesses, people can get depression. So when they come, they talk about depressive symptoms. They don't know to differentiate, but they talk about depressive symptoms. But as doctors, as physicians, we focus on already diagnosed physical illness. And then we miss some depressive features among those set of symptoms. And then social stigma, as I explained you. Physician factors, like, not only by patient factors, but physician factors. We also sometimes miss depression because of we have very limited time. In GP practice or in other specialties, and even in psychiatry, we don't have enough time because our caseload is very high compared to the other countries, especially the European countries. And then we tend to focus on the somatic symptoms. We as doctors also tend to focus on somatic symptoms. If there's a pain, we invariably automatically prescribe some painkillers. And then we feel patients should report key features of depression, because we have a picture depression. They have to have this low mood, sleep disturbances, and suicidal ideas, and most common among doctors and other healthcare workers, most common expected feature is crying. We all expect depressed patient kenek nang andanna ඕනේ. And what depression and නැත්තම් it's not depression. No, it is wrong. So the crying is not a key feature of depression. It could be, but it's not a key. And unaware that psychological problems sometimes underlie this physical complaints. And they're unaware that depression can amplify symptoms of chronic diseases. And concerned that suggestions of depression will be interpreted accusing or malingering. This is also very important. Many doctors, especially general practitioners and other consultants in other specialties, they reported me like when they diagnose depression, and then when they tell patient, okay, you have this psychological issue or depression or whatever the way they explain, they don't want to accept. And then we also think, may patient mata kiyapu de mama mehema depression කියලා කිව්වොත්, if we think it is depression, and then the client might think we are accusing him or we are accusing her, may බොරුවක් කරන්න කියලා. No, it's not. So that is the one challenge that we have to overcome, to convince the people with depression that you have depression. It is a big challenge. And then stigma again, not only patient factor, the physician factor also. We also don't like to say that this client has depression. Right. And some of the key facts about depression. 6 months before being diagnosed with depression, depressed patients made an average of 3.5 self-initiated visits to their family physician. This is important. We delay the diagnosis of depression. When we diagnose our client, our patient, as having depression, 6 months before they have come to us, it's the number of visits 3.5. And important thing is this: those are self-initiated visits. Patient himself or herself wanted to come and tell you, doctor, I have a problem. But it's not, I mean, you might not diagnose depression, and as well the patient might not, tell about the depressive features. Maybe some other features, physical complaints or other ways. And it's that is how we miss this diagnosis. And depressed patients visited health facilities 2 to 3 times more frequently than people who do not depress. It's about 91% of individuals consulted their GP on at least one occasion in the year before death. This is about a suicide. Look, 91%, 9 people out of 10 who committed suicide, they have visited their GP, and importantly in this research they said they have somehow given a clue that they're going to commit suicide, not in direct words. So if we are alert, we can prevent 90% of suicides. And that is why this is important to know these things. So how can we do better? This is what we all have to learn after knowing few facts about this depression and suicide. We should not expect depressed patient to present with obvious signs and symptoms. Like I said, like ICD-10 or DSM-5 criteria we learned in medical school or later on. We should not expect they come and people with depression come and say those 3 classical features or the minor features of depression. No, they won't. I'll tell you. These are some of the cases that I have came across. 46-year-old female came with abdominal pain, regurgitation, vomiting on and off, and she was extensively investigated and treated, but symptoms persisted. So all of the healthcare system, they were going behind the gastroesophageal reflux. This is GORD, but later on we found that she had depression, and we treated with a simple SSRI for 2-3 weeks, and she improved a lot, and then we continued it for 6 to 8 months. That's it. And then this depression can present like GORD. This is, I don't tell you, like I don't suggest you straight away with GORD patients treat with antidepressant. No, you have to look, as you all are doing, look for all the other causes of GORD, and if it is not resolving, and then think about this. The second one, 33-year-old postpartum mother, 3 days after the vaginal delivery, she complains of this. This is actually not a complaint. Like when this is a true story. When the house officer visited in the morning, like we all know that house officers are really busy in post-natal wards. What actually this mother said, doctor, I will tell you in the exact words, because the inquiry went and then we were involved. Doctor mata amuttak danenawa. And then obviously, even to a psychiatrist, like even she told me, like I might not alarm. Okay, all right, api our discharge karani niyada gedara giyata passa siyallam hariya. Then at the time of discharge again, she said, Doctor mata hari wenas wage, mata hari අපහසුතාවයක් දැනෙනවා. Then that was not a physical complaint. I mean, actually that house officer was a good person, and that doctor inquired about, any abdominal pain or anything. No, but perfect. And then she went. The day 17, that was the day 3 this happened, and the day 17 she developed depression throughout the 2 weeks of the home stay, and no one didn't pick. Even the midwife's visit was not happen, unfortunately. And what actually happened, she had another child, 7-year-old child at home. She killed that child and then jumped into a well with the 17 days old child, the second child. What actually happened, she lost 2 children, but she survived. And she was taken to the custody, and then we had to provide a report, comprehensive report to the courts as forensic psychiatrist. So this is what actually the complaint was, Dr. Mata Venaskama there. We don't think that this Venaskama is a depression, but it happened in this country, it happened in this area, in this Colombo district. So we have to be very careful about dealing with patients. That was a postpartum depression. I mean, for that case, we cannot penalize anyone, but have to be little more alert. That is the lesson. And then third is 47-year-old male is overspending. We all know, even a small child knows overspending is a one feature of a mania. Right? It's mania. I mean, nothing to worry about. We can straight away in the MCQs and anything. But the life is not a MCQ. This patient actually was treated for mania. And then we later found the exact question why we need to be alert. This patient was overspending. No one asked about this important question, why he giving away his whole money and then whole property. The answer, when we asked that, the answer was, doctor, I have a plan, a very clear plan of taking away my life, committing suicide. Before that, I wanted to give away everything, every cent to other people. So that was his plan. That is why we actually observed it as overspending. No, it was a clear plan of committed suicide. Before committing suicide, he wanted to give away all his money and the other properties. So overspending itself, not a mania. You have to dig into that. And depression with suicidal ideation. So this is how this is a classical depression we don't see in day-to-day practice. In special features in Sri Lankan population, because we all know that we don't do, I mean, now we do a lot of, researchers and studies, but earlier we didn't have that culture. And we know that some of the features of depression, actually those were established in other countries by their researchers. But in Sri Lanka, depressed people sometimes present with GORD. As I told you, as I explained in the case 1, gastroesophageal reflux disease. They have extensively investigated with giving antacids, starting with giving antacids and then up to the upper GI endoscopy, CT scans, X-rays and everything. But finally, everything was normal. And then the diagnosis is depression. And then irritability is another common feature, especially middle-aged female irritability. I mean, not only females, but males are also common, but especially middle-aged female, all of a sudden they become irritated. Diagnosis more closer to depression. And the somatic symptoms, as I explained you, involving 2 or more systems, could be depression. And poor educational performance, especially in these days, we see in all ages, all of a sudden, school children or the university students, they drop their educational performance and could be depression. I have, in our clinic, we have treated, as a team, we have treated many, school children. They had a sudden the gradual onset of, reducing the performance of the school performance and exam performances. And finally, the diagnosis was depression. And when we treat with simple antidepressants, they improved remarkably. So think about this. And then increased use of alcohol and cigarettes. Sometimes people say, doctor, I'm using alcohol and cigarette, but these days I feel like I use more. It could be depression. This is the Peradeniya depression scale by Dr. Ranila Basing and the team. They have developed the features in our culture, because as I told you, like we use this ICD-10 or DSM-5. Those are not the facts, and the data is from other countries. But for us, in our culture, these are some of the symptoms. This is very important slide. Then you will see, you will meet. When you think about your day-to-day practice, you might see these people. Like these biological symptoms, like these people in our culture, people present with these symptoms and then look for depression, insomnia, loss of weight and loss of appetite, and some somatic symptoms like burning sensation. They present to us and saying, Doctor mage anga devillai. That is how they present. Anga purama devillak enawa. So think about it. Could be depression. And headache, chest discomfort, aching pains, discomfort of limbs and joints. And how they explain is Vata Amaru. Vata Amaru is a generalized discomfort. Vata Amaru is how they present. So these, we don't see these in ICD-10 or DSM-5 because the data is from other countries, but in our country, the patient present like this. In the abdominal fullness and feeling of faintishness. Some features of depressed effect. Mata sankava wage. Some people say, mata epa vela, mata sankava wage. The sankava, when we dig into sankava, we can see this patient is depressed. Then only we could see the classical features of depression. Badegindara, anger, irritability, and sadness. And some depressed cognitions, like ideas that life is not worth living, and fearfulness, suspiciousness, loss of self-confidence. But then, most recently, I had a patient in the clinic, a tuition teacher. He said that he lost his, the income because he cannot teach as such as earlier. So finally the diagnosis of depression, and then we treated him. And then some people say bad karma. Mage karmata vecha deyak, mage karma nisa mata kisi deyak karaganna bෑ. Just check with them. They might have features of depression. Right. And then related to depressive behaviors. Neglect of duties. Sometimes they neglect their duties at the working place, at home, or towards family, and socially withdrawn, and they tend to live alone, stay in dark places. They cannot tolerate the noise. Sometimes people say, Doctor mata ගෙදර TV එකක් රේඩියෝ එකක් දාලා ඉන්නකොට සද්ද අහගෙනම ඉන්න බෑ. It's a feature of depression. You don't see it in classical textbooks, right? How can we do much better, provide much better service? Effective communication is utmost important thing, because as doctors, not only with patients with depression or patients with psychiatric conditions, with all our clients, we have to have this effective communication. We have to know these things. And I think if we are, I don't say like most of our doctors have bad communication skills, but some, a fair amount, that we are good people, but we don't know how to properly communicate. That is why in everyday practice we see newspapers and in other Rupavahini channels and television channels and others, people are they blame us, like they scold us, even a minute things. But actually think about your service. And in the hospitals we do our best, and I have worked in other countries. Though we don't have much physical facilities compared to the other countries, we are giving a much better service than them. But the only problem is our communication is far behind than their communication skills. So that is why we need to have this. I mean, don't think about depression, or don't think about any psychiatric patients. So think about a patient who come to your clinic or your private practice or the channeling. So first thing is you have to be relaxed. You have to be relaxed. Mulin tamang relax වෙලා that patient always catch. Patient is coming into the room and looking at you. And that is why some people have a very good practice, and then some people, even they are very good doctors, but they don't have good practice. They are not relaxed. If we have everything goes in our mind, like our family matters and all sort of things, then the client, our patient, might catch it. So you have to be relaxed. And then the second is you have to relax the patient as well, and then give him some time. Let him sit properly and to be relaxed. Second thing is, do not jump to the complaint. This is the, even the psychiatrist and all the other doctors, this is the, the major issue we all have. When patient starts to tell doctor, I have abdominal pain, then the very next second, we try to ask questions thinking, okay, this abdominal pain could be appendicitis, so likewise, the surgical cases or the medical cases, and then all go into, it's like a computer in our mind. We try to sort it out and ask number of questions. That is not good practice, and then people might not come to us again. So usually what we advise is listen to the initial complaint for at least 3 minutes and then you are done. If we can listen carefully to 3 minutes of the patient, sometimes within that 3 minutes people might give all sort of unnecessary and less important things, but listen to those 3 minutes, all these unnecessary things within these 3 minutes, you can get more important symptoms and signs and the features that you can diagnose very correctly even without some investigation. So take your time, listen to them for 3 minutes and then only start questioning back. So that is very important, especially not only in psychiatry, in other specialties. At least give them to 2 to 3 minutes and then you are done. And try not to be judgmental. Right. How can we do much better? Find out underlying psychological issues. Like, how do we ask that? We all have learned many things about this, the psychological issues, how we diagnose, how we elicit, but we don't talk about the ways of eliciting it. ගොඩක් අය අහන්න දෙයක් තමයි කොහොමද ડોක්ටර් අහන්න කොහොමද මේක දැනගන්නේ කොහොමද සර් මේක දැනගන්නේ කියන එක. Sometimes we ask questions that the client or the patient, he or she has to go to some other doctor to get the explanation of it, like, because they cannot understand our question. That is again the way of communication and the words. We have to be very careful of using words. A few examples, like, how do you ask? හිතට කොහොමද දැනෙන්නේ? Then it's an open question. People have to answer. මොනහරි කල්පනා කරන ගැටලු ප්‍රශ්න තියෙනවද? Maybe not ගැටලු ප්‍රශ්න. මොනහරි නිතර කල්පනා කරන ඔළුවට වද දෙන ප්‍රශ්න තියෙනවද? Or else we can ask, වෙනද වගේ සතුටින්ද ඉන්නේ? And especially for the GPs, they are listening to us. People, they are very open with general practitioners than the specialists, than the consultants, because the GP is like their family friend, the family doctor. So they are open with them. If we ask it, they might not answer, in the first instance. But if the GP asks, then they start telling. So GP is a more closer and more reliable person to these clients. වෙනද වගේම සතුටින් දින්නේ. වෙනද වගේ ආසාවෙන් කරන දේවල් දැනුත් කරනවද? ඔයා මේ දවස්වල ආසාවෙන් මොනවද කරන්නේ? And people might say, අනේ ડોක්ටර් මට කිසිම ආසාවක් නැහැ, කිසිම දෙයක් කරන්න උවමනාවක් නැහැ. So that is how you have to learn these Sinhala words also too. That is a skill. So then only you will get the real out of the patient. How can we do better? Right. You have to be confident about treating depression. That is another issue. Many GPs, they said, "Ane, sir, I will refer to you." I said, no, you don't have to refer. This is very important. Take this message. You can treat depression. Why you are not treating depression? In all the other countries, GPs are treating depression. Then why not you? You all are much, much better than, because I have experience working in other countries. You all are much better than them. So why don't you treat depression? Sometimes people say, doctor, sir, we cannot, take that much of time because we have to listen. I have a huge practice. No, you don't have to listen to them for hours and hours. Just ask to talk to them and listen for 3 minutes without disturbing. That's it. That's enough. Treating depression, I will tell you. Depression, this is the outcome. If we don't treat depression, 20% will spontaneously settle, but 80% will suffer. And then if we treat with placebo, yes, 30% again will settle, including this 20% of spontaneously settling people. And then if we start antidepressant, 50% will improve. And then if we give ECT, electroconvulsive therapy, 80% will improve. There are two classes of antidepressant. Initially I told you this is not a lecture to psychiatrists, but for the the people who are treating the other patients. But day-to-day practice, you are come across with these people. So these are basic things of antidepressants, like two classes, new and classical. Newer is like SSRI, selective serotonin reuptake inhibitors, SNRIs, NDRIs, and a lot of other groups. But at least if you know one or two groups, and to initially start off with medication, and then if patients are not settling within 1 or 2 months, then you can send to a psychiatric services. But initial stage, you can treat. I'm very sure that if you treat in a GP practice or in your clinics, I mean, more than 60 to 70% of people, they don't have to come to our special clinics. So that is good for us as well. And then we can treat for the most needy people. So the newer antidepressant like SSRIs, SNRIs, and NDRIs, SNRIs, selective serotonin and noradrenaline reuptake inhibitors, and this NDRI is noradrenaline and dopamine reuptake inhibitors. The classical antidepressants are, as you all know, like tricyclic antidepressants, TCAs. The examples are imipramine and amitriptyline. So in modern days, we use the selective serotonin reuptake inhibitors, SSRIs. You all know there are many medications like fluoxamine. Fluoxetine is the most commonest medication used in our country. Sertraline, again a common thing. Paroxetine, citalopram, and escitalopram. There are more SSRIs, but these are the most commonly used medication. Out of these, fluoxetine and sertraline are the mostly using medication. SSRI, let's say sertraline, we say it's a fairly safe medication. People with the other comorbid illnesses like angina, the other myocardial infarctions, post-MI, renal problems, liver problems, we can safely use this sertraline, starting with 50 milligram in the morning. This is for adults, starting with 50 milligram in the morning, because we give morning, it can cause insomnia. So we give as a morning dose, and then you can increase by 25 milligrams or 50 milligram, but don't be rushed. Wait for 2 weeks at least, and then check the improvement. After 2 weeks, you can increase. So start with 50, then you can increase up to 75, 100, 150, and go up to 200 with 2 weeks interval. And then fluoxetine, it's only a capsule form. It's 20 milligram in the morning, can go up to 80 milligram by 2 weekly, 3 weekly, or the 4 weekly, depending on how patient improve. These are some of the side effects. You won't have to worry about these things, especially the GI side effects like nausea, loss of appetite, dry mouth, and the constipation, and uncommon like vomiting and weight loss. It's not a common thing. And CNS like headache, insomnia, dizziness, anxiety, and other symptoms, side effects like sweating, delayed orgasm, and anorgasmia. But importantly, we don't usually use SSRIs people with bleeding. It can increase bleeding tendency. So people with bleeding tendency, we don't usually start off with SSRI, but still we use in cautiously. I mean, in your setup, it's better not to use with people with bleeding disorders. And some of the drug interactions can occur. Fluoxamine and theophylline, we cannot give we can give, but the effectiveness is less when we give with fluoxamine, the SSRIs, because the cytochrome P1A2 can inhibit. And then fluoxetine with clozapine, the two, one antidepressant and one antipsychotic. And then paroxetine, again SSRI with tamoxifen. So those are some of the drug interactions. And I told you that SSRI can cause, not can cause bleeding, but it worsening the bleeding tendency, and mostly administered in the morning because it can cause insomnia. But very rarely I've seen some people, they said this is they get a bit drowsy with SSRIs, then I change to as a nocturne dose. So could happen. You are free to give it in the morning or at night. And switching and stopping, we usually do not stop this SSRIs abruptly. I mean, nothing serious, but can have some withdrawal effects. So what we do is we reduce one medication while introducing another one. Let's say like we reduce fluoxetine from 60 milligram to 40 for 2 weeks and 20 for 2 weeks while introducing the other medication. And sometimes there are researchers say that suicide rate among adolescents can increase with SSRIs. Imipramine, TCAs. It's imipramine. We can start with 25 milligram starting dose, and we can go up to 200 milligram. The very important thing, this message I am giving because I have seen many doctors, including all the other specialties, consultants, GPs, they give for depression, they give, they clearly diagnose depression and then they give only 25 milligram or 50 milligram of imipramine or amitriptyline. Amitriptyline, yes, amitriptyline or imipramine 25 to 50 milligram, it's a sedative dose, fine, you can use, but it's not an antidepressant dose. To get the antidepressant effect, you have to at least to give 75. Right? And tricyclics, you have this cardiac risk because you can have depressed patient with suicidal ideas. If it is, if they take overdose, it is toxic than SSRI. So people with suicidal ideas, we don't usually give TCAs. And it can cause anticholinergic side effects like dry mouth, constipation. Treatment resistant, if we treat with 2 antidepressant and adequate doses and with other psychotherapy like cognitive behavioral therapy, if it is not improving, then it is treatment, we call as treatment resistant depression. And then we check the diagnosis, check again whether diagnosis is correct or not, look for other etiological maintaining factors and check the drug compliance, the medication compliance. Sometimes we diagnose resistant, but people, they haven't taken their medication. Resistant, if it is resistant, then we can combine fluoxetine with mirtazapine and venlafaxine with mirtazapine, and then fluoxetine with olanzapine with antipsychotic and fluoxetine with a mood stabilizer, lithium, and then add thyroxine. Those are, I think, better to, keep these things to a psychiatric or the, the psychiatric healthcare workers, the MOMHs or the diplomats, and then treat for the simple depression. ECT is electroconvulsive therapy, just for the completion. It's usually used for very high risk people and the postpartum mothers especially. And then the resistant depression, people who don't get adequate improvement with oral medication, we give for ECT. Relapse prevention, if it is more than 3 episodes, we sometimes have to give lifelong treatment, no other option. And then we continue the effective smaller dose. And then sometimes we give long-term lithium therapy as a mood stabilizer. And then add with cognitive behavioral therapy, psychological therapies, and give some advise some lifestyle changes and other therapies. Right. Finally, depression is related to, strongly linked with this suicide. These are some of the myths associated with suicides. We also, even the healthcare workers, we also, don't know some of these things. These are the myths. The suicidal patient, they do not reveal it to others. Suicide කරගන්න කෙනෙක් කාටවත් කියන්නේ නැහැ කියලා myth එකක් තියෙනවා. No, they actually do tell to others. And they do not tell the reason before. ඒගොල්ලෝ කවුරුත් අපිට කිව්වේ නෑනේ. අපම දැනගෙන හිටියානේ අපරාධ මේ මනුස්ස මන්නේ. They no, actually more than 90% of people, they have revealed before suicide. The problem is we haven't picked it up properly, and suicide cannot be prevented. Another myth, no, we can prevent it. And asking about suicidal ideas is harmful. This is one common myth among the doctors. Suicidal ideas explore කරන එක හොඳ නෑ, ඒක suicide එකකට අපි push කරා වෙන්න පුළුවන්. No, that is wrong. You have to elicit it and then promptly treat or refer. And the all needs medication. No, they don't need medication. All of them, they don't need medication. For some, yes, but the others, we can, even without medication, we can prevent suicides. And all are mentally ill. No, people who committed suicide or the people who are planning to commit suicide, they all are not mentally ill. There are some other causes other than psychiatric problems. The final slide is for us, for you all. Doctors in stress. As we all know that we are in stress, and there are a lot of researchers says in throughout the world and even in among Sri Lankan doctors, we are in a high risk category of stress. Our stress is very high. That is why our people have more alcohol and substance use. We skip meals because of our stress, and we have lack of sleep. We don't sleep adequately. And another problem, we have a lot of extramarital affairs. That is, and they have found, the researchers, that because of the stress, we try to find some other less stressful things, like we pick the wrong things, and then it will become another additional stress. And then anger towards the clients and staff. Sometimes we see people are, blaming and scolding the other people, especially doctors, the clients and the staff. And then finally we see that they are depressed. So, and then lack of leisure activities. Only leisure activities we have, like we all get together in the weekend or maybe Friday, and we take alcohol and other substances. That is the only leisure activity we have. That is a completely unhealthy activity. So think about, if you all have these things, maybe one or two things, think about, you might be in extreme stress, or you are a depressed patient, though you are a doctor. Thank you. And I think I tried within this limited time period, try to give you just a message to overview, like we have depressed patients in and around us, and we day to day our practice, we see them, but we can miss them. So try to catch and then effectively treat them. Don't worry, don't bother about sending them to the psychiatrist. All patients, start treatment and then try whether there's improvement. If not, then refer. Okay, then. Thank you, and we'll give some time for the questions.
Thank you very much, sir, for the interactive and very useful presentation. It's time to enlighten few queries. If you have any questions, please use the chat box to clear your questions. And we are really happy to see more than 90 participants today, even during this long weekend. And thank you all for your participation. Now it's time to enlighten few queries. We have few queries from the participants. So the first question is, when should we refer patients to psychiatrist after diagnosing depression?
Right, as I told you at the end of the lecture, you don't have to refer each and every depressed patient to psychiatric services. And it's a simple thing, like if they don't have any risk like suicide or homicide, if they have the risk of suicide or homicide, if they say doctor mata jeevithe epa wela thiyena, then it's better to refer to psychiatric services. But otherwise you can treat, you can start with SSRI or simple tricyclic antidepressant, treat for 1 month, and then you can see the improvement. I'm very sure that majority of patients will improve, and then you can treat them. Otherwise, if they are not improving within 2 to 3 weeks, then you can refer to a psychiatrist unless they have an imminent risk. If there's imminent risk, of course, yes, straight away you refer. So then you can filter.
Thank you, sir. One more question. Do you suggest counseling prior to the antidepressant?
It's again, it's again depending on the patient. Sometimes, if it is a mild depression, their functional ability is not impaired. They are doing their day-to-day work, but still they have some concerns and they have some features of depression. Then you can start antidepressant and then do counseling, because counseling is only for mild depression. Depression, we can have 3 categories. I didn't go into detail: mild, moderate, and severe. For moderate and severe depression, no, you don't have to start counseling first. First treat with antidepressant and then only go for counseling. But mild depression, of course, yes, we can start with counseling and then check the improvement. If it is improving only with counseling, that's fine. But if it is any risk involving a risk of, as I told you in the lecture, like risk of self-neglect, not the higher risk like suicide or homicide, even with abuse or self-neglect, you don't start counseling as the initial step. So my advice is, even for mild and moderate depression, if you are feeling like starting antidepressant, you start antidepressant, and by the same time you can start counseling. That is a combination therapy. So best thing is to do counseling plus medication.
Thank you so much, sir. Please kindly mute your microphones. One more question from Dr. Dineshan. If patient with depression with chronic back pain And if patient is having continuous pain, how to differentiate it due to depression or due to chronic pain?
Right, a good question. As I discussed in the lecture, if a patient comes with a back pain, first thing is you have to investigate about the back pain, try to find out all the organic causes. After finding out it, I don't say that, I don't suggest to go up to MRI level. First, they try to with a minimal investigation. And if it is not improving with, the analgesics and other treatment options, then just think about depression and ask few questions. Then you can see whether this patient is depressed. Then treat with antidepressant. But there are things that you can coexist. People with back pain, even though you treat effectively, there's organic cause. But even you diagnose that organic problem, you treat, the pain is not disappearing, because that is scientifically proven that the pain can worsening in depressed patient. If a patient is depressed, they feel more pain. So then it is again a combination therapy. You treat for the organic cause with analgesics and other options, and add some antidepressant to relieve depression. Chronic pain is can go into even a suicidal level. So people with chronic pain, they have committed suicide because of the pain. And therefore, the pain is the depression. In depressed patient, they feel more pain than the non-depressed patient. So the answer is, Dinesh, that you can investigate for back pain, start treatment. At the same time, you can check the improvement of the pain. If not, then check for depression and simultaneously treat for the both.
Thank you, sir. One more query from Dr. Lokashini. What about overdiagnosing of depression? Because labeling a patient with depression also causes stigma in society.
Yes. Again, overdiagnosing. Overdiagnosing is also not good. So for that, what I suggest is, like, sometimes most of the people, they don't like to label as they have depression. So best thing is, if you are thinking like moderate to severe depression, of course you can definitely say that, look, you are not eating properly, you are not taking your things, and you are functionally deteriorating. So you can definitely convince them very easily. This happens only in mild depression. So they are doing their job, they do their day-to-day work, they don't have that much of functional disability. So it is very difficult to convince those milder depression patients. What I usually do is, like, I ask them, depending on their education level, I ask them to check about these symptoms. Even now, they have these smartphones. Even a small kid, they have their smartphones. So check about depression and check about these symptoms. What is it? Maybe we can say you are a little more stressed than you were. So check about these things, and then the next day they will come and say, doctor, I think I have depression, and then you have to treat me. It happened to me in many times. So people, even though that is again, I don't say it a myth. It's again, the doctors, as doctors, we think people are not willing to take this, accept to diagnose. No, when we convince them properly, sometimes we are not directly convincing. Ask them to search about those things, or to talk about your family doctor, and then come back again if necessary, because it's not the urgent thing to treat mild depression, and they will come back most definitely.
Thank you, sir. One more question. How a depression patient with doctor shopping differentiate from somatoform disorders?
Yes, somatoform disorder is, again, as I told you, like people who have complaints of body aches involving more than two systems, like maybe respiratory, CVS, and CNS. Likewise, 2 or more systems involving many complaints. It is not connected rationally to each other. And if it is persists for more than 6 months, and we say that it is a somatoform disorder. Usually the somatoform disorder, people tend to do doctor shopping, because they go to some particular doctor and get the treatment. If it is not resolving, and then they go to another one, then to a consultant, different consultant, and do all sort of investigations. So usually somatoform disorder people do doctor shopping. And then there are small amount of people, they do doctor shopping. That is not because of somatoform disorder. Actually, that is something other psychological issues they have that is not diagnosed as somatoform disorder. Some other psychological issues like, for example, like attention seeking. Some elderly women, I have seen some mothers, they just wanted their children to come and visit them. Those people also, they actually deliberately, go for doctors and doing doctor shopping to get the others' attention. So that is different from somatoform disorder.
Thank you, sir. One more question from Dr. Menik. Is there long-term side effects from ECT that prevent the patient refrain from doing a job which needs ability like pilot?
No. That is again a very good question about this ECT. Many people ask about this ECT. In our country also, ECTs, they think it's a huge thing. It is a huge thing as far as we give a few seconds of, we need few seconds of general anesthesia. That is the only thing. Otherwise, compared to all the other oral medications, side effects are less. Only side effect we know is like it can cause temporary memory impairment. Usually it disappears soon after ECT. It's only about 3-4 hours. In the evening, like we give ECT in the morning and in the evening, they become normal. Sometimes even within a few hours. This transient memory impairment can go up to 28 days. I mean, that is very rare that we can see go up to 28 days. Usually within few hours, the next day, because that is why we give ECT in every other day. We give today, and we don't assess this patient that day, and then we'll assess the patient, then improvement the next day. So we have the ability to assess this the patient in next day after 24 hours. Then patients are completely, conscious, rational, and then the memory is intact the very next day. Majority of the patient, but very rarely can go up to 1 or 2 weeks. So this transient memory impairment is the only side effect. Otherwise, compared to the other medication, it is safe and effective method. And the exact question answering, no, not to become a pilot, or we don't have any category to say that, okay, you cannot be a pilot, you cannot be a doctor, you cannot be a politician, or, anything. If you are capable of doing that, you have that skill, the depression or giving ECT it's not matter.
Thank you so much, sir. We have a limited time. So last question is, what is the best drug for depression? Is it fluoxetine or TCA? Normally, for how long should we continue?
Now, we cannot say what is the best drug. It is, as I told you, it is depending on the client requirement. If a patient with, for the effectiveness, you can say, you can initially start with TCAs or else start off with SSRIs. It depending on the patient, the other requirement, like the other comorbid illnesses. Like if a patient comes with an old elderly age patient and with high risk of suicide, we don't usually start tricyclics, because with tricyclic it can cause side effect like anticholinergic side effects. And then with high risk of suicide, if they take overdose, it's cardiac toxic. So because of that, those people we go for SSRI. But sometimes, for example, like postpartum period, in postpartum mothers, lactating mother, we know imipramine, one of the tricyclic antidepressant is imipramine, is one of the safest thing, because it cannot pass through breast milk. So we start imipramine. So that is depending on the situation. We cannot say this is better than the other.
Thank you very much, sir, for such a very good explanation for all of our queries. If there are no more queries, I would like to thank Dr. K.H. Dhanusha Mahesh for his excellent and informative presentation on behalf of the GMOA and Society for Health Research and Innovation. Now, I call upon Dr. Chandika Pitakaruwa, Consultant Histopathologist and Vice President of GMOA, to present the token of appreciation to Dr. Dhanusha Mahesh.